Good evening, good afternoon, good morning, wherever you are tuning in from. I'm Simon Platt, joined by Laurent Garossi, and welcome to Neurology for Vets Journal Club webinar series, where we hear directly from the author about a recent neurology study. And today's session is sponsored by Hallmark Veterinary Imaging, so thank you to Hallmark for that. We are honored to have a previous presenter on this series, Dr. Theofanis Liatis. Obviously, Theofanis, we didn't put you off last time, so thanks for coming back. Theofanis is a rising star of the profession, but for those that you don't know him, here's a little introduction. He graduated from Aristotle University of Thessaloniki, I hope I got that right, in Greece in 2015. He did a one-year internship in small animal internal medicine at that university, and then moved to the UK working as a general practitioner, and did some neurology internships at Dick White Referrals, University of Glasgow, and the University of Edinburgh. Subsequently, completed a 3-year residency in neurology and neurosurgery at the Royal Veterinary College in London, and has this year become a diplomat of the ECVN. So congratulations, Theofanis, on that. And currently undertaking a PhD in tremors. You're currently doing that, or have you completed it already?
Completed.
You completed it. Congratulations on that as well. So we've got the perfect person to talk to us today about tremors in dogs, based on a recent publication called Generalized Tremors in Dogs, 198 cases. And I should say that Theofanis, currently you're also based at Southern Counties Veterinary Specialists in the UK. So thank you very much for coming back even. I'm going to hand over to you so that everyone can hear about your study. Thank you.
Thank you very much for the nice introduction, Simon, and thank you for inviting me again, both you and Loren. I'm going to present to you guys today about the study we did in the Royal Veterinary College last year. It was part of the PhD, but I didn't manage to have it on time, so I left it for afterwards. The topic name is Generalized Tremors in Dogs. The question we had was mainly what are the main diseases that can be potentially associated with the manifestation of generalized tremors. So we searched in the PubMed and Google Scholar as well. We found very, very few papers, one of which was quite old, 1990 something. The first paper, the Wagner et al., they included 24 dogs. The majority of them was diagnosed with the idiopathic generalized tremor syndrome, what some people call corticosteroid responsive tremor syndrome, or Weizsäcker disease, or idiopathic cerebellitis. So we don't have a consensus about that. And then quite new paper, the second one, the idiopathic generalized tremor syndrome in dogs, which was very dedicated to this specific disease, including 75 dogs and presenting a lot of things, between them clinical signs and manifestation. So our, as I said, aim was to describe the semiology, the tremor phenotype, and the diseases associated with generalized tremor in dogs, but also to identify any potential clinical features that could be associated with a specific underlying disease. The material and method, starting from the fact that it was a monocentric study, a retrospective one, just based on the RVC. The time period was a quite large period, from 2003 to 2023. The inclusion criteria included full medical records, the presence or report of generalized tremor alone or accompanied by other clinical or neurological signs, with all the limitations that this can include, and having a final or presumptive diagnosis. The videos were not necessary, as they were not available in most of the cases, especially due to this large period of study. And then we did some basic statistics, initially descriptive, and then univariate and multivariate analysis. So our results, first of all, to say that the dogs that met the inclusion criteria were 198, which for me was a quite large number to handle, comparing with previous studies I had done. I hadn't done such a big one, so it was a bit of a different approach. Then we found out that we found out that 18 different diagnoses were associated with what was called generalized tremor in the records. The most common diseases found was acute intoxication, by far the first, 46%, and followed by the idiopathic generalized tremor syndrome, which was around 25%. Then the remaining diagnoses were by far less possible, like hypocalcemia, 6.6, MUO, 4.5, hypoglycemia, 3%, hyperglycemia, and degenerative encephalopathies. From the intoxications, the most common was the unknown one, because as everybody knows, we don't really send from chromatography, so we don't really go to the etiological diagnosis, as there is not any point most of the times. We didn't have enough information to suspect mycotoxin. So the second was mycotoxin, 31.9, and again here I point out that we speak about suspected cases. We didn't have any photometry. Then the third intoxicant agent was metaldehyde, especially in older times. We couldn't find this for the last 5 or 10 years. Then avermectins, 6.6%, and cannabinoids, 4.4%. And then we described and we studied a lot the tremor phenotype, which I'm going to show you a video. So here we have an idiopathic generalized tremor syndrome dog that had generalized tremors. Most of them usually did have kind of a fine tremor. Sometimes it was not even easily visible. I suspect because of the high frequency. We haven't really done any electromyography in these dogs, so we don't exactly know the frequency. Some of them had tremor of the eye, what we call opsoclonus, and some of them mandibular tremor with this very nice sound. Then we had the acute intoxication dogs that were a bit more serious cases in the ICU with generalized tremors. I say tremors in quotes because it could be also myoclonus or fasciculations. And then more metabolic diseases that the tremors were more episodic or quite fine, quite difficult to describe the phenotype in particular. Hypocalcemia dog. And then a hypoglycemia dog. Again, a classic one that was manifesting quite episodically. Then we did the statistical analysis. Clinical variables of dogs with intoxication were compared actually with dogs with IGTS. And this was done because these two major categories had the biggest number of cases. So it could potentially give us a bit more accurate results. So regarding the signalment, we found out that there was more statistical significance in the manifestation of acute intoxication being males and young and middle-aged, comparing to the IGTS, where most of the dogs were female and younger. The onset and presentation was different between the two groups. Usually the intoxication had a hyperacute, non-progressive, symmetric presentation. In contrast, the IGTS was more acute progressive, often lateralizing. I say acute because I speak about some days, like from 1 to 5 days, and often lateralizing, mainly speaking about a potential lateralization of the ataxia, of lateralization of any potential head tilt if present. Then we studied the presenting complaints. Behavioral changes and hypersalivation was more likely to occur in intoxication. Hyporexia, on the other hand, was more likely to occur in the IGTS. I suspect likely because of the nausea. Then within the neuro exam, more dogs with just tremors as the only neurological finding was more likely to be intoxicated, whilst less of them were in the IGTS group. From a neuro finding point of view, dogs with abnormal mentation, bilateral mydriasis, or generalized hyperesthesia were more likely to have an intoxication. In contrast, dogs with titubation, head tilt, forelimb ataxia, and cranial nerve deficits, overall, I would say more vestibulocerebellar signs, were more likely to be IGTS. And this is translated into the neuroanatomical localization, that the intoxication tended to be more multifocal, the IGTS tended to be a little bit more vestibulocerebellar. From a tremor phenotype of view, obviously it was a very difficult job because we speak about records, and consistency is not something that we usually see in the records. We didn't find so many intentional features, and I mean intention head tremor in the intoxication, whilst in the IGTS group, more dogs had intentional head tremor, which means more cerebellar signs. The trunk and limbs plus minus head was affected in intoxication, whilst in the IGTS, usually on top of the generalized tremor, you may have had mandibular tremor, palpebral tremor, or the dancing sign, which is this sign whilst the dog will lift the one leg in order to relieve from the tremor and put the other leg down, and vice versa, what we have seen in the past with orthostatic tremor. And regarding the treatment and outcome, we saw that there was statistical significance in the improvement in dogs within 48 hours without steroids, exclusively in the intoxication group. Okay, and all these variables were statistically significant in the univariate analysis, not in the multivariable. So just to know, yes, this is for the steroids. So I would say overall the take-home message is that we should probably reconsider a little bit the diagnostic approach to generalized tremors, maybe including more electrolytes, maybe including the ionized calcium by default, including ammonia, because we had some cases with hyperammonemia. Then we should keep in mind that there are two most prevalent diseases in dog presenting to a clinic with generalized tremor. And I say that because we didn't really have an abundance of diagnoses. We had particular numbers, and two of them had by far the biggest percentages, and this is the intoxication and the IGTS. Then maybe we should keep in mind a little information that we could get for the signalment. Maybe the IGTS will present more acute progressively, will be few days of ongoing signs, in contrast with intoxication that you have a quite acute violent onset, which doesn't really obviously progress, and potentially history of something have to be eaten from the rabies or something like that. Then time is quite important because, as I said before, we saw that within 24-48 hours, there was a quite different phenomenology between the two diseases. The IGTS was actually getting worse, whilst the intoxication was actually getting better. So there was this big difference. And then that, as I said before, clinical pathological evaluation should at minimum include CBC, biochemistry, including glucose, ionized calcium, electrolytes, ammonia, plus minus bilateral stimulation test for a dog presenting with tremors. And obviously not yet in animals, but in humans, they do have these genetic panels by default, 3 pages of genetic mutations that they check for animals with generalized tremor diseases. I would like to thank Stephen and Sophie for their help in this study. And you can find the study in the GVAM, is open access. And I'm happy to take questions. The only thing I want to mention, because I like this information as always, is that it's very interesting when I realized that there was the actual word tremor in ancient Greek, which is the one that we use in the current Greek language, in the Homer's Odyssey. Exactly the same, meaning the fear that was spread among Greeks from the gods. So it's very interesting. That's for anyone who is interested in the history. Thank you very much.
Thank you very much, Fanis, for this great presentation. Let's see if there's any question from the audience. I think there's one for you. So the first one is from Cecilia, which I'm sure you know. Hi, Fanis, amazing study. Do you know by any chance how many of the dog diagnosed with intoxication receive intralipid before improving?
I don't have the number. We have some number in the, I should know probably because I wrote it. So there were, it is recorded in the paper, and it is included in the supportive treatment. So most of them, I remember from both categories, they were receiving intralipid. So there was not any particular tendency that, only the intoxication were receiving. So there is a quite equal number, but it's not for all the dogs, because this also became more popular after a particular year.
I think for the people listening, probably the question would be, would you recommend, on the dog where there is no intoxication to use intralipid, or if it's unsure, will you use it, blindly as well? Is it something you will recommend?
Yeah, that's the general, I would say, understanding from the whole presentation of the case is that because we don't know what it is, and we cannot know actually without time or diagnostic investigations, and even then you still cannot know 100% in the IGTS cases, we would definitely suggest like treating as if it was an intoxication, which means supportive treatment with intravenous fluids, with intralipid emulsion, with active charcoal if it is very fresh, a very acute manifestation, plus minus the bloods and the diagnostics that we mentioned before. The main thing that we'd like to pass through the paper is that we wouldn't start steroids without giving some time. That's the main actually message from the treatment point of view.
Yeah, I think it's good for the people listening, but there is nothing to lose really giving intralipid in this case, I don't see any other questions, so we're going to give a bit more time. One question I wanted to ask you is, did you see any difference in terms of the possible or the suspected cause of tremor, whether or not they persist during sleep or anesthesia?
We tried to put it actually in the parameters to be calculated and to be recorded, but the records, because there's a big period of time, very big inconsistency because there were too many residents from this particular center, like too many senior as well. So it's very difficult to follow. Not every record would say what's happening under general anesthesia or sleep. So we have some information, but we have a lot of asterisks that, these numbers, we are missing the information. So we cannot really make any obvious conclusion from what was persisting. But I would say the little information is that usually the peripheral nerve hyperexcitability type of tremors, which means, for example, the intoxication would potentially persist under GA or sleep, whilst the tremors, like the IGTS cases, wouldn't usually. But we had very, very few numbers, so I don't think we can make a conclusion.
Tanya, wanted to make an observation. Tanya wanted us to share with everyone that intoxication sign can be progressive longer than 48 hours. In case of MDR1 defect. So just to remind people, if it lasts more than 48 hours, it can still be obviously, a tremor in this case. We got Lawrence as well. Everyone can read the question, but Lawrence wanted to, ask you about the mycotoxin and the high number that you had in your study, whether all, confirmed, meaning that was it witnessed every time that they had, eaten moldy food?
That was a difficult one. This was kind of an assumption based on the records. Then the most common mention was that the dog ate the moldy bread. So it was very straightforward, and that was useful. But the rest was mainly a little information that the dog ate from the bin, and there was a highly suspicion of that from the clinician. So I didn't judge at the second level, as the one who was recording the information. So it was mainly based on what the clinician had just based on the history that they had. But we didn't really have any phasmatophotography.
No, of course.
Like nothing, zero case. And just to mention to the previous question, we did have cases that were more than 48 hours. So as a general rule, definitely. And regarding the second question about IGTS, no, because obviously I cannot speak about dancing sign in this large population. This we found in particular cases, which usually we had the video, so it was not something that was reported. Although it doesn't have a statistical power in the study because it is only taken from the cases that we had the video. We wanted to report because I really have seen this particular dancing sign, which differs from the hypermetria. In orthostatic tremor, we have reported, it is reported from the past, I think from Lorraine, in orthostatic tremor, but we saw exactly the same in live animals or in videos, which means what is happening during this sign is that they lift one leg and they stay on the other, or they shift the body weight to the other, like all the time, like for a little period of time. We supposed to relieve themselves from the tremor. That maybe is annoying. We don't know. In humans, this is the speculation in orthostatic tremor cases. But it was interesting to mention because we thought that is connected with orthostatic tremors only. But it's something to keep in mind. It happened also here.
And I think what Lawrence was also mentioning is probably more in the gait. I think some of these cases are, cerebellovestibular. And as part of that, they could have vestibular sign, but also the cerebellar component, which is having some form of hypermetria. That's probably the thing. Let's see if there's any more question. In the meantime, I can ask you, frequently this dog go through, having an MRI, and is it actually something that you think is worthwhile? And because my feeling is that a lot of the time, MRI would be normal in this case. So pose the question, are we actually, putting this animal through, all this expanse and, maybe unnecessary test? So what will be your guidance? If you have a dog with generalized tremor, will you put MRI in your list of tests?
I think that's a very nice question and a bit tricky because I would answer this question based on the signalment, if that makes sense. So if I have a very young dog, for example, that has a different presentation, that is more rare, doesn't belong to the statistical findings we had, I would potentially consider, because degenerative diseases, as we said, probably will be seen not always in the MRI. But if we speak for the general population and what we see every day in clinical practice, I think that's a kind of indirect message that maybe time is more important because maybe this will lead us what to do. And obviously, we do MRI for cases who are IGTS, but even for these cases, we usually find the MRI normal. And sometimes we even find the CSF normal. And it's a matter of us learning about these cases. But to be honest, we find everything normal. So I don't know, in the future, maybe that we will have more experience with these cases. Maybe we change the approach, as we do with sometimes with idiopathic epileptic, that we don't scan as much as in the past. So I wouldn't rush for an MRI. This would be my final answer. I wouldn't rush. I would give some time. Then the majority of the list we found in the etiological diagnosis doesn't really have an MRI explanation. Is it a metabolic thing, or is it intoxication, or even if it is a disease of the CNS, we may find nothing. So it's tricky.
That's why, I was asking because, again, people tend to rush in to do MRI and CSF and all that, but taking a step back, very often you don't see anything on MRI. Again, you're totally right. If it's a very young dog, different population, there may be another cause for the tremor. You could even push it, further to the CSF in that some of these dogs with IGTS will have inflammatory CSF, and you could say, well, it could help you, give you confidence it is that. But if it's normal and the owner swear there was no intoxication, you may still end up treating them the same way. So then pose the question.
True. I'm always begging for a CSF to be lymphocytic in that cases, but it happens that it may not be.
Bottom line for people listening, if you got a case, you can probably summarize. If you got a case with tremor, you don't have access to MRI, what would be the test that you will do? Is probably a good way to summarize the topic.
I would definitely work them up as if it is a systemic disease with potential intoxication. So I would do like a CBC, I would do a serum biochemistry. The serum biochemistry has to include the electrolytes, has ideally to include the ionized calcium. So probably venous gas blood would be useful. Ideally ammonia if accessible, because you can have hyperammonemia and have tremors and can be the only clinical pathological finding. Bile acid stimulation, this is a little bit more advanced, but again, if you don't have ammonia, this is why I put it in the list, so you can at least check the bile acid. Not that is necessarily, if the one is elevated, you still can have a problem with ammonia only. In humans, they do the magnesium. We don't do it, but maybe something to consider for the future.
And obviously, if you know how to do a CSF, probably do CSF, because if it's inflammatory, then we help you to in bracket confirm a GTS, but if it's normal, it doesn't rule it out. So it probably be so in summary, you don't need an MRI to diagnose this case. That's unless it's the young category of dog. Thank you very much, Theofanis. Simon, you can have the last. Word.
Thanks, Vanessa. That's a fascinating topic. Great work on tons of dogs. That's excellent information. So thanks for that. Thanks for coming on again. Thanks to Hallmark for sponsoring this session. Thanks to everyone for tuning in. A recording of this presentation is going to be available on the Facebook site as well as on our website, which is web-vetneurology.com. So click on that and see what else is on the site. So join us again in a couple of months for our summer edition of the Live Journal Club. But until then, thanks for tuning in and goodbye.
Thank you.